Welcome. Waterline care is a challenging and complicated part of infection prevention and control in every dental office. Let us discuss the various dental unit waterline systems, the treatments currently available, their advantages and disadvantages, as well as what is involved in achieving and maintaining safe water. Throughout your day at the office, do you wonder if the water you're using is safe? What are you doing right now to ensure your water quality meets current guidelines? Have you reviewed your dental unit waterline protocols recently? Are there improvements or better solutions available? Why is all of this so important? Contamination in dental unit waterlines is highly probable thanks to the ideal conditions created inside the lines. Long, thin tubes, minimal amounts of water, flowing short amounts of time only when instruments are in use. Otherwise, the water is left stagnant throughout the day. Factor in poor or minimal maintenance. And what do we have? The perfect spot for biofilm and bacteria to grow and multiply, which can happen as quickly as every 20 minutes throughout the day. Needless to say, we can all see how quickly this situation can get out of control. What is the real danger of contaminated dental unit water? Well, nothing. Until the dental water lines are used and the bacteria, biofilm, fungi, and protozoa are released. Any of these microorganisms can now be ingested during patient treatment, or worse, entered into the bloodstream or inhaled due to aerosol production from rotary instruments. Did you know that the water from a high-speed drill creates a 4-foot diameter circle of potentially contaminated aerosols? Anyone present within this circle of mist is at risk of ingestion or inhalation of bacteria and biofilm. Ingestion of unsafe water can cause mild temporary health effects. However, inhalation or entry into the bloodstream can produce more severe consequences with long-term effects, infections, hospitalization, or even death. We have seen over several decades a wide range of health effects related to contaminated dental unit water, putting both patients and dental professionals at risk. How can we reduce the growth and/or eliminate these potentially hazardous pathogens? What treatment options are available to provide safe and compliant water for our office? What type of dental unit water system does your office have? There are two distinct types, each with different ways to achieve acceptable water quality. The first system is directly connected to municipal water. It releases continued inline disinfection to dental water. These systems are located separate from the chair, usually in the back of the room. Basically, the system cleans or processes city water and sends it up through the dental chair. Examples of types of disinfection used in these systems include hydrogen peroxide, ultraviolet light, filtration, and ozone generators. As these systems treat and shock automatically, they are reliable and effective. This convenience and efficacy, however, comes with a high installation price. An independent water bottle system is the most common, cost-effective method to control waterline contamination. It is a closed system where the water source comes from the water bottle attached to the chair. Since this water is isolated from municipal water, there is greater control over the water quality. Quality is maintained by adding chemicals daily and/or periodically to the bottle. This system relies on the consistent and precise work of dental professionals, who happen to be human. Humans get busy. We may forget, and alas, not always follow protocol. The task of continued chemical maintenance can be labor-intensive compared to inline disinfection. Maintenance may involve chemical mixes, which can be complicated, and some chemicals can affect your equipment or even interfere with water testing results. The installation cost is cheaper than a directly connected system. However, there is an ongoing maintenance cost over the years. Here is a summary of methods that reduce the risk of dental unit water contamination within your system. Equipment, products, and protocols can be combined to meet the goal of safe water, which in our industry is less than 500 colony-forming units per milliliter. Let's take a closer look at the pros and cons of each method. Different methods of achieving acceptable water quality do not apply to all systems. Directly connected systems use various types of inline water disinfection to purify or treat incoming municipal water in order to remove or inactivate microorganisms. An autoclavable system is an option here. Independent water systems require periodic or continuous chemical treatment to the water bottle. Combinations of the above treatments, such as anti-retraction valves and flushing lines, can be applied to any type of system to help reduce bacteria. The American Dental Association and the American National Standards Institute recommend anti-retraction valves be installed in all dental water lines, directly connected and bottle systems. The job of an anti-retraction valve is to stop or reduce pathogens from being sucked back from the patient's mouth into the water lines. Unfortunately, these valves do not stop all bacteria, and additional methods are necessary, such as chemical treatment to the lines and pre-treatment antimicrobial rinses for patients. Functioning and maintain anti-retraction valves reduce the chances of introducing non-waterborne bacteria into the dental unit water lines. Several studies clearly show biological fluid retraction in dental unit water lines during patient treatment does happen. We tested 5 different water sources in an operatory, all of which contained varying bacteria exceeding the acceptable water quality limit. The cavitron was the most contaminated, and the water test detected 152 different species of bacteria. Among the findings were non-waterborne pathogens that prefer a much warmer environment. These are bacteria typically found in the human mouth or respiratory tract. Also on the list, E. coli, parasites typically found in stool, and parasites commonly found in the mouth of a dog or cat. At the top of the list, you'll see Geobacillus. Does this sound familiar? Geobacillus stereorothermophilus is used in the healthcare industry to test the effectiveness of sterilization cycles. It is the bacteria from your biological indicator test strips. Geobacillus is non-pathogenic and therefore not harmful. However, think about how this could have gotten into the water lines. How easily bacteria can transfer from a surface to the water, then into a mouth, into a bloodstream, into the air, or your lungs. Think about the importance of personal protective equipment, surface disinfection, and hand hygiene. Close all infection control gaps. The next option to controlling waterline contamination for any system is filtration. Always check with the chair manufacturer first, if they recommend a filter for your dental unit. For those systems designed for filters, a pore size of 0.2 microns is recommended by the U.S. Federal Drug Administration. Disposable filters are recommended, which must be changed daily. For maximum efficacy, filters should be inserted close to the point of entry of water into the handpiece. Designs with pleated filters have a larger surface area for filtration. Filters do prevent bacteria from entering the oral cavity and from producing aerosols. However, replacing filters is time-consuming, and some offices experience reduction in flow rate. Filters also have no impact on biofilm formation. Flushing dental unit water lines is a well-exercised and established protocol for any system, and mandated in most countries. Dental unit water lines should be flushed for a minimum of 20 to 30 seconds between patients to discharge oral fluids that may have bypassed anti-retraction valves. All water lines and handpieces should be flushed for at least 2 minutes at the beginning of the day to reduce the bacterial load from stagnant water conditions that may have occurred overnight. Several studies have concluded flushing water lines for a few minutes provides only temporary reductions in bacterial load and has no effect on the biofilm. Flushing removes free-floating microbes, but is unable to remove microorganisms present in the biofilm that has adhered to the waterline walls. Studies also found that flushing was relatively ineffective in removing Legionella and Protozoa from the dental unit waterline. The Centers for Disease Control guidelines recommend that flushing alone is not a reliable procedure for improving water quality, and additional methods, such as the use of chemical agents, are necessary. Ultraviolet light is an ideal and effective inline disinfection method. This type of system disinfects automatically and requires very little regular maintenance. You may have to change a light bulb every few years, but that's about it. As effective as UV light is, some UV-resistant pathogens do exist. The UV light is installed in the back of the room at the beginning of the water journey, which is not as effective as it would be located at the end, right before the handpieces. Remember, even if one bacteria survives the UV light, it can grow and multiply in the line. UV light can kill bacteria, but it will not prevent biofilm formation. On a side note, there have been recent discussions regarding the combination of UV and chlorinated water in drinking water treatment, and the possible production of toxins. Like UV disinfection, ozone, chlorine dioxide, and hydrogen peroxide are all newer technologies to dentistry, which can be both a pro and a con, as there is still a lot more to uncover. This system consists of a fully autoclavable assembly of water reservoirs, silicone multi-lumen dental unit waterline tubing, and fittings. It is ideal for high-risk applications and is highly effective in eliminating live bacteria from entering the system. Autoclavable systems are not without challenges. The autoclave cannot remove biofilm. It actually hardens it. The tubing needs to be sterilized between patients, or if disposable tubing is used, it needs to be changed between patients. This is why an autoclavable system would not be efficient for the quick pace and high traffic of a regular dental practice and routine procedures like cleanings. However, it would be an excellent solution for portable dental systems or disposable systems used for surgical procedures. Overall, an autoclavable system is very safe, but labor-intensive, time-consuming, and expensive. Let's move on to independent water bottle systems. In these systems, waterline contamination is controlled using biocides and chemical disinfection. Chemicals can be distributed in two ways. 1, a cartridge or a straw, or 2, with liquids and/or tablets. A cartridge or straw is a dosing system that continuously releases a low level of biocides into the water bottle. Straws are fairly easy to install and require very low maintenance. They are available in a 90-day or 365-day use, which means no daily work between replacement cycles. There is some work involved when it comes time to remove and replace the straws. Straws also need to be completely removed for shocking. Yes, shocking is still required. Remember, this is still a low-level antimicrobial release, not enough to deal with established biofilm. The most common straws are iodine or silver-based. Iodine and silver are different chemistries with specific pros and cons. Iodine is an oxidizer. It breaks down or oxidizes the bacteria cell. Its release into the waterline can be inconsistent, and therefore you must monitor the level of this disinfectant with iodine test strips to ensure its effectiveness. The antimicrobial benefits of silver are well known, and silver has been used for this purpose in several ways over centuries. There are restrictions on silver in drinking water in some U.S. states, mainly California. Silver is considered a heavy metal, and thus it is important to be aware of the level of silver in your water. It can damage lines and leave deposits on metal parts. Silver inhibits bacteria from multiplying by binding to it and suffocating it. Silver is only released into the water when bacteria is detected, whereas iodine releases continuously, regardless of the amount or lack of bacteria present in the water. If you are not using a straw or cartridge, your maintenance will include either a liquid or a tablet, or maybe both. Common chemicals used to control dental unit waterline bacteria and biofilm are as follows: sodium hyperchlorite, chlorhexidine gluconate, povidone iodine, hydrogen peroxide, peracetic acid, ethanol, glutaraldehyde, quaternary ammonium compounds, silver nitrate, silver citrate, and citric acid. The application of these biocides include periodic shock treatment or continuous treatment, or both. Not all biocides have the same effect on biofilms. Sometimes different biocides are used for shock versus maintenance, and sometimes the same biocide is used for both shock and maintenance, but in varying concentrations. Tablets are convenient, fast, and require no dosing. Just drop one into the bottle and go. The tablet, however, does not always completely dissolve, and there is potential for chemical buildup or tablet residue in the lines. Both daily maintenance treatments as well as shock treatments are available in tablet form. Liquids are easily and evenly dispersed into the water. There may be some mess and precision required to accurately measure the liquid treatment. However, sometimes the product comes with a dosing pump to make this job a little easier. Controlling bacteria and biofilm in your dental unit waterline is not simple or easy, even with the different types of systems and methods available to reduce bacteria. Implementing this 3-part system provides complete dental unit waterline care and the best chance for safe water: shock, treat, and test. Each plays its own role, and any waterline protocol or system would be incomplete if we were missing any of the three. This graph does not show all possible treatment scenarios, but it does show one very important fact. Shock treatment plus daily treatment is more effective than maintenance or shock alone, boosting an 88% pass rate. Also, without testing, we wouldn't be aware of how effective our protocol even is. This confirms the three-part system of shock, treat, and test is in fact essential. When planning your dental unit waterline protocol, always consult the manufacturer of the dental unit and/or the manufacturer of the waterline treatment product. They are your best sources to determine the following: how to achieve water quality less than 500 colony-forming units per milliliter, maintenance and monitoring frequency, as well as compatibility among chemicals and system components. Dental unit waterline maintenance treatment consists of a low-level antimicrobial, which reduces the chances of bacterial growth in your water lines. Its job is to control. These cleaners or disinfectants must be low level because this is the water being used every day during patient treatment, and therefore can be ingested by patients. Maintenance treatments for an independent bottle system consists of daily tablets or liquids, or continuously by installing a cartridge or straw. A directly connected system provides continuous maintenance through automatic inline disinfection. Daily or continuous treatment to your water lines is not enough. This low-level antimicrobial is not strong enough to do the job on its own. Though it will reduce the growth of bacteria, it cannot handle established biofilm. Think about a swimming pool. What is required to open the pool is quite different than regular weekly maintenance. Also note that shocking allows your maintenance product to do its job more effectively. So when should you shock? You should shock according to the manufacturer instructions for use. You should shock when you have new equipment, new protocols, or new products being used. You should shock quarterly if you're doing ongoing maintenance treatments, and weekly without ongoing maintenance. And lastly, you should shock when your water test fails. There are many products on the market available to shock your dental unit water lines. Tablets and liquids are available to do the job. It is still necessary to shock lines even with a straw or cartridge in place, but remember not to shock through the straw itself. Use a dummy straw. As the shock is not a low-level antimicrobial, it is essential that it is flushed completely from the lines. Some tablets and liquids are tinted in color so that you can easily ensure that they're in the lines to do their job and then out of the lines for your patient safety. As these treatments are stronger and thus tougher on bacteria and biofilm, keep in mind they may also be more corrosive too, such as in the case of bleach. Did you know bleach is 20 times more corrosive than hydrogen peroxide and 100 times more corrosive than iodine? Some manufacturers recommend to shock using diluted bleach in the lines for a maximum of 10 minutes. Bleach can be corrosive if it's left in the lines. It absorbs into the waterline material and can make the plastic tubing brittle. It is also hazardous if ingested by patients, so take extra caution ensuring your lines are bleach-free as it is invisible in water. Any biofilm in the lines when mixed with bleach can create perchlorinated compounds, which are known to be potentially carcinogenic. Nonetheless, bleach remains an easily accessible and cheap solution. Regardless of which shock or maintenance treatment you choose, always follow the manufacturer's directions for use. 2 items to keep in mind where relevant are as follows. The first is inadequate contact time. For most chemical treatments, the effects of shorter than recommended treatment times are unknown but unlikely to be beneficial. The second is improper dilution. Dilution can influence treatment efficacy. However, just as dilution that is too weak is likely to be ineffective, dilution that is too strong is likely to cause damage to dental equipment. Regardless of which shock or maintenance treatment, we have spoken about the importance of maintenance and shock. But without testing, how can we know if what we're doing works? There are many variables to consider when it comes to safe water, such as following manufacturer's instructions, staff compliance of waterline protocols, the design of the dental unit, the frequency of use, the efficacy and compatibility of treatment products, and input water quality. Even if a treatment protocol has excellent efficacy test results in a laboratory setting, placed in a real-life situation, combining the above factors, the results are not the same. This is why testing is so important. There are two ways to test your water: right in your office or using an outside laboratory. In-office testing is more economical than lab testing, as it is done by you on-site versus off-site at a lab with trained professionals. As your office staff performs the test, the results are for your eyes only. They belong to your office and are 100% confidential, whereas lab test results are documented and available upon request. Testing in-house means you and the water sample don't have to go anywhere. There is little chance for sample contamination, as the test starts immediately following the sample collection. Lab test requires that you send your samples via mail. It is essential to follow directions precisely. Samples must be mailed immediately and kept in cool conditions. Time and heat will work against you. Delays and poor storage conditions can cause bacteria to increase quickly, producing inaccurately high results. There are in-office tests that are fast and produce results in just 30 minutes. This quick turnaround allows you to test in the morning and be sure of acceptable water quality before the first patient walks in the door. Lab results need more time. They need to incubate and can take anywhere from 7 to 14 days to get a result. Both tests produce accurate results. However, a lab test is quantitative and tells you the CFU per mil, how many colony-forming units per milliliter there is. In-house testing is intended for screening. Rather than give you an exact colony-forming unit count, it lets you know if your water quality meets a designated detection level. It is either a pass or fail result. Certain testing methods can be beneficial in certain situations, depending on your office needs. Sometimes a combination is ideal. Some in-office test manufacturers recommend lab testing once a year as a third-party verification. Lab testing uses the heterotrophic plate count, HPC, currently the gold standard in water testing. When choosing an in-office test, look for their proven efficacy. Do they have results comparable to HPC? How frequent do we need to test our dental unit water lines? Well, OSEP tells us first to always follow manufacturer's instructions for use when it comes to testing recommendations. When there are no manufacturer directions available, which may be the case for older equipment, OSAP recommends that periodic monitoring and inspection should be performed according to the directions for use provided by the treatment product manufacturer, or at least monthly on each dental unit or device. If monitoring results indicate that water quality is acceptable for 2 consecutive monthly cycles, the frequency of testing may be reduced, but this should not be less than every 3 months. When a dental unit exceeds the action limit for an initial or periodic test, the unit should be treated accordingly to manufacturer instructions and retested immediately after treatment. Creating waterline protocols can take time and effort to get them right. If you've ever experienced dental unit waterline frustration or failed tests, you are not alone. Just look at this stat. 31% of treated water lines still fail, and 61% of offices have at least one failed water line. So what are the top reasons for failure? 1. Not shocking ever or enough. Without some kind of periodic shock, your low-level antimicrobial maintenance products will not be able to work as effectively. All of their power will be consumed on the biofilm and will not be able to reduce the bacteria in the lines. 2. Not following product instructions for use. It is important to follow exactly what your manufacturer tells you. After all, they know your equipment or product best. Pay attention to dilution rates, frequency, and application time. Number 3. Poor source water. You may be doing all the right things, but if the initial water source is contaminated, further measures are needed. If you're using unreliable city water, you may need to consider point-of-use filtration, adding a filter to each tap or even filters for the water lines. What is the mineral content of the water? Is the content of the water interfering with the action of the disinfection product? Certain chemicals are affected by water hardness, such as peracetic acid, chlorine, and hydrogen peroxide. They all lose effectiveness in hard water. Also, tablets dissolve slower in hard water. Number 4, using distilled or deionized water to fill your water bottle. Tap water, at the very least, has some chlorine protection. Distilled or deionized water has none or very little built-in defense against bacterial growth. Extra measures are needed when dealing with distilled or deionized water. If you're using deionized water, have you addressed the need for an additional antimicrobial? And lastly, number 5, not following waterline testing shipping instructions and cross-contamination of sample vials. This last one applies specifically to the mail-in lab testing, where you must ensure your sample remains uncontaminated. The time from sampling to testing needs to be within 24 hours. Samples need to be stored and shipped in cooled conditions. If you do not follow the instructions precisely, you may end up with a test result that does not reflect your initial sample. Here are 2 other possible failure culprits we've come across. Are the bottles clean, disinfected regularly, and aired out at the end of the day? Contamination can occur easily if bottles are not washed and stored properly. They need to be kept dry. We know how much biofilm and bacteria love damp, wet areas. Wash bottles first to remove biofilm before replacing the water. Remember, when you're shocking your lines, you're also disinfecting the bottle. Did you know autoclavable bottles exist? This may be an option for you. Is the microtubing kinked or bent? This can be a culprit for high bacteria counts. A kink leaves a damp area free from flowing water, where biofilm and bacteria have ideal conditions to establish. We have discussed a variety of waterline possibilities for consideration to provide acceptable water quality for a safe environment for everyone in the office. You have all the pieces. How will you put them together? Every dental office is unique and requires a unique solution to achieve acceptable and compliant water quality. It may take a little trial and error, new products or equipment, or it may be as simple as ensuring your staff is trained and following protocols. Always test. This really is the only way to see if your choice of treatment works with your dental unit system, your protocol is correct, and your water is safe. Thank you.